It's time to turn down the noise and tune in to News You Can Use, the show that gives you a quick insight into the latest twists and turns in healthcare news, where every diagnosis comes with an order of side-splitting humor. Your hosts are Dr. Nick, a longtime host, innovator, and healthcare wizard who can prescribe a digital dose of innovation to cure even the most ailing operational inefficiencies. And Dr. Craig Joseph, the healthcare guru who can diagnose both patient and software glitches with equal precision, making sure hospitals run smoother than a well-oiled robot doc. So buckle up, because we're diving into the ER of excitement, the ICU of irrationality, and the waiting room of wacky wisdom. Now here's Dr. Nick and Dr. Craig.
Welcome to the month of April. I'm Dr. Nick.
And I'm Dr. Craig.
This week, we'll be dissecting the latest healthcare news, unraveling the twists and turns, and making sense of some of the debacles.
Just remember, life's a lot like a breaking news story. Unpredictable, often absurd, and occasionally leaves you wondering if it's all just a cosmic prank.
This week, we'll take a look at user design and divorce, and the National Physician Advisor Conference, or NPAC.
And we dive into emergency medicine and obstetric care, and obstructive sleep apnea and risk with AF and strokes.
But first off this week, we have the latest news in AI and large language models, and what's going on with paywalls and cyber attacks. So, AI, it seems to be our sort of trending topic these days, and where are we with that? Well, I think we're in this sort of continued improvement, but not the sort of revolution that we all felt when ChatGPT emerged on the scene. And it's still incredible. But one of the things that I've been reading a number of times now is folks are saying some of these other models are pretty good. And I've had some experience with the other models. They come with different pros and cons, but certainly Claude, which I've tried, used, I was super impressed with when I tested it out with a test, and it did really, really well. And then I hear Llama, which I think is the Facebook group, has leapfrogged or is potentially leapfrogged over some of the other models. So I think overall, I'd say interesting times. Keep testing all this stuff out, but no quantum leaps ahead. But there's some other things going on as well, right?
Well, absolutely. And to your point with the different models, I think it's kind of like going to be, what kind of car do you like? You know, they're all going to be good, and one will come out with something good. And to some people, they make a choice of a car based on how big the cup holder is. And
this is apparently true in the United States. We don't have cup holders in the UK.
No, well, we have them. They're required by law. I actually don't know if that's true, but they should be. And some people do make those decisions. And so I think what you're going to see is, oh, well, I use ChatGPT for this, and I use Llama for that, and you'll get to your favorite. But
right, so it's like your garage where you've got, if you've got to get somewhere fast, you take the Porsche, and if it's the family trip, you're taking the Range Rover SUV, and you pull out the different cars at different times. Then, Craig,
I feel like you're contributing to stereotypes that all physicians are incredibly wealthy. And so I don't have either of those kinds of cars. Those are not decisions that I get to make, Nick. Apparently, I've made some bad decisions in my life in not becoming a brain surgeon.
Well, I'm sorry to hear that, but hopefully at some point you'll get to choose your cars.
I did want to kind of mention an article that came out in JAMA last week about physicians using an artificial intelligence to prepare a response to patients who queried them via the patient portal. So many people have something like MyChart, or might be branded a different thing, but you send a message to your doctor and say, hey, I've have these symptoms, or this thing's come back, or you mentioned I should do something if this thing happened, and here it's now happening. What should I do? And physicians have gotten, over the last couple of years, especially since the pandemic started, really overwhelmed with just so many messages, many of which would have been phone calls or in-person visits. And so we're trying to do as much as we can to help physicians with this deluge. And one thing is to see if an AI can kind of craft that message for you and then let you just tweak it a little bit. And what they found, what they were hoping to find, was that this was going to save physicians time because they could just look at it and go, yep, that's a really great answer, click send. What they found was it didn't really save a lot of time. In fact, because physicians were fairly heavily editing some of the suggestions. Now, some of this is because AI is not the godsend we all think it is in terms of being able to diagnose and treat. Some of it, however,
I'm glad you said that.
I'm there for that. Some of it's, though, in the AI's defense, it doesn't get access to the entire medical chart at this point. It's only getting a small subsection, a very small subsection of the information that the physician and all the humans know about you. And so it's a little unfair to be asking it to do these amazing things. That said, it didn't save a lot of time. It did, though, however, make physicians happier, and it kind of decreased burnout and increased morale. And what they found when they studied, hey, what changes did these physicians make to the AI-generated response? It often the physicians left in the sentence or two or three that was typically at the beginning of the message, with kind of the empathy part, what some of us might call the fluffy part, like, wow, really sorry to hear that this happened. If it's bad news, this is unfortunate, but we're going to work through it. That kind of thing. Physicians left that in and actually appreciated that. And I think that's a popular part of the message that the patients are seeing. And that was probably missing a lot because physicians were going to try to get through this mass of notes and responses as fast as possible.
I think I got to say, I think it's a physician thing. Maybe it's not. And, there's an N of 2 here because, well, no, maybe some more from the study, but my own personal experience with notes, and let's just talk about regular email. I get an email, I'm replying, I hammer out literally 1, 2, 3, here are the answers. And then actually I go back up to the top and I put the niceties in and the stuff at the end. I do it afterwards because, it's important, but it's not sort of built into my natural. So I'm not surprised to hear that. And I think it's good because that bleeds through, and I think it's important for the patients.
I get it. The closest I can kind of relate to this is when patients used to call me, or parents. I'm a pediatrician. Usually the patients don't call me, but I got feedback once, I think my first year of practice, from the office manager. Someone was a little perturbed that when they called me at 11 p.m. for something that, in my opinion, was not urgent, was not a new question, something that should have been addressed during several days when our office was open. The feedback was that I wasn't as pleasant at 11 p.m.
Shocking.
as I was in the office. There was no small talk. There was no pleasantries. It was just the facts and just the response, and that's it. And this mom was unhappy with that, and my response was, well, I don't feel I'm going to change very much. But I can imagine, answering after message after message after message.
Yeah,
you said you kind of just answered it and then put the pleasantries in. I think a lot of doctors just skip the pleasantries.
Well, and I think, the LLMs allow you to create something that's a little bit variable because, if you just cut and paste, it's not quite the same.
No, of course not. But so that was an unexpected kind of positive that the physicians, even though they didn't save much time, at least at the beginning, were pleased with the pleasantries, and the patients are pleased in reading the pleasantries. And so I'll chalk that up as a win.
Well, I think that's good news. You mentioned change, and since you mentioned it, we'll talk about Change Healthcare. I think that's still an ongoing challenge for folks, and the cyber attack that has debilitated large numbers of organizations. Lots unfolding, but it brings us to the whole issue of paywalls, which I gotta say, I got a bee in my bonnet with all of the investments made with research that is funded by the government, the NIH, and you can't get to most of these articles, they're paywalled. There are ways around it. But you went to look at an article and couldn't get to it.
Well, I was a little perturbed because I couldn't get to an article that I feel I paid for. No, I couldn't get to it.
From a
But
journal you subscribe to,
I
right?
subscribed to it, and so I thought I could get everything in it. But they're like, "Oh no, some of this content is cost extra." And so
No, yeah, that's the Ferrari level. You didn't buy.
I didn't. I was only at the Porsche level for this particular website. But as I was mentioning to you as we were preparing for the show, I managed to get around it. Two different ways. One is there was an option to have it read it to me. Yeah. So hey, read the article out loud. Well, it read the whole article, which was great. It just when I looked at it, I could only see the first 3 sentences. But when I asked it to read it for me, it read the whole thing. So I assume they'll fix that at some point, but they haven't fixed that yet. And I tried another thing. I can gift an article to people who don't subscribe. And you get a certain number of those options every month, I think. And so I tried gifting to myself. At first, it didn't work, but then I said, "Ooh, I wonder what will happen if I use a private browser tab, which removes all the cookies." And so
I'm shocked you even knew what private browser.
I do.
Was, but okay,
I'm an expert.
We'll read something
privacy.
into that. I'm not sure.
Yeah. That's fine. It's a free country so far. Yeah. So I went to a private browser tab and pasted that gift article in. That again, let me emphasize, I could not read. But when I gifted it to myself, I could. I could read it again. So yeah, things are. Yeah, it's good. It's the scientific method, Dr. Nick. I'm just applying the scientific method, and yeah.
You were jumping through all the necessary hoops, and thank goodness your tech chops were sufficiently good enough. I'm just going to say Sci-Hub right here.
Let me emphasize, Dr. Nick, that I do subscribe to this particular periodical.
I got that.
And so I felt like I should have had access to it, and I don't want to hear from any.
And you did. And we haven't revealed it, so we're not.
No, we have not, and we shall not.
No. Okay, so recent study. I think this was another epic, which is one of your favorites, right? This is the obstructive sleep apnea of somewhere that I spent a lot of time. Sleep, and there was a study just out of Gallup that published that we're getting less than 25% of what we want in terms of sleep. It's worse for women. 1942, when they first did the survey, 60% of people got more than 8 hours, and we're very happy with the amount. So anyway, obstructive sleep apnea, which is a clinical condition, to be clear, but there was some research. Tell us what was going on there.
Yeah, this is, again, I think we've referenced this a number of times. Epic is a big electronic health record vendor globally now, and they have access to a lot of data. And so they've to try to spur people to use some of these data, they have done. I'm going to say research, but I'm going to say research with air quotes, right? So it's not a peer-reviewed study, and their goal is not.
I'm sorry, no, it wasn't those air quotes. Sorry.
Yeah, no, not B. No, their goal is not to change perceptions or to change what we do. Their goal is to push people to say, like, "Oh, that's interesting. We should do a more formal study of that." And so they're kind of just very preliminary. But what they did, because they have access to so much data, they looked at 3.9 million atrial fibrillation patients, AFib or AF, almost 4 million AF patients, and said, "Hey, are there more patients with who have AFib?" And we know that if you have AFib, you're at higher risk of having a stroke. How does obstructive sleep apnea play with that? And what they found was, if you have AFib as an underlying condition and then develop obstructive sleep apnea, your risk of having a stroke is higher. So that was something that I think has not been clear, but is probably now more clear, at least than it was before. Again, these are all very preliminary and not peer reviewed. I want to be clear about that. Another interesting aspect of this study, though, was that they looked at the major model about predicting someone their risk of having stroke if they
Right.
have some problems like atrial fibrillation. And what they found was actually the model does a pretty good job of predicting your risk of stroke, whether you have obstructive sleep apnea or not, which was not expected. One would expect that if you don't even ask that question and the model doesn't take into account you having obstructive sleep apnea or OSA, then the model would give you a lower risk than you actually have, and they did not find that to be the case. So, again, I think it's just an interesting use of a very, very large data set. I think Epic is trying to use it for good and not for evil. They don't seek to sell any of these data sets.
Right.
And
they're all public. There's no paywall.
There's no paywall to their little mini studies, exactly, and all of the data are volunteered by their customers, the hospital systems. And so, if a hospital system is uncomfortable with this, they don't have to share their data. But if they do share their data, then their researchers have access to it in a de-identified way. And so, again, in this case, they found 3.9 million AFib patients. They couldn't give you their names of those patients, but they have lots of demographic information about them.
I think what it says is that, these the data, large data blocks with all of the information provides really good content for generating insights through these machine learning, artificial intelligence tools that can essentially see signals in there that we, as humans, certainly the ordinary ones, I knew a few consultants that I worked for that seemed to have that artificial intelligence that could walk into a room and just grok the patient just like that. But, for the rest of us, they elevate us all by finding some of these things. I mean, that's certainly what I've been seeing, which, makes for more interest, more excitement. Anyway, moving on. I came across an article that it stood out to me. Let's just be clear. It was essentially a user design issue. It was a user interface design, and in this particular instance, it was the law court system for lawyers, and the user design had been so confusing that a lawyer had clicked the wrong button and ended up divorcing his clients by mistake. And they were committed to fixing this. And it wasn't a huge piece, but what was really interesting to me was, that's just divorce. And I don't mean to diminish divorce as a thing, but, for those unfortunate enough, it's not life or death. But user design is like a critical issue in healthcare. And this was just one example where, hey, you clicked the wrong button. We've seen some examples. I mean, you're knee deep in this. So knee deep, you decided you'd write a book about it.
I did. I co-wrote a book called Designing for Health, The Human-Centered Approach. Came out last year. And we talk about, a colleague of mine and I talk about how easy a lot of this stuff is. Really, it's not. I mentioned a few minutes ago that.
And you say easy, what do you mean? Easy to get right? Is that what you're saying?
It's easy to get less wrong.
Okay.
Yeah. You don't need years of training and master's degrees and to be a brain surgeon to figure out a lot of these things. When you just look at them and understand some of the basic principles of human-centered design and user-centered design, part of the problem is intentionality, right? You have to kind of sit down and think, hey, who's my target audience? Who's going to be using, in this case, I think we were talking about some web page or some sort of technology. So, who's going to be using it? If you're 20 years old, the target for clicking a button is much smaller. You can make it much smaller safely than if you're 60 years old. Right. Or if you're 80 years old, right? We can't see as well when we get older and our dexterity decreases and we get a little shaky. And so the risk of those things happening are greater. But even that, one of the very first things that we talk about in the book is stealing from one of the founders of human-centered design, Don Norman. And he went and looked at doors, as in the things that you walk through to go from one room or one building to another.
Do you know, I'm so glad you clarified that. I would have been confused otherwise.
Listen, you just talked about grokking, and you also talked about having a bee in a bonnet, which I'm assuming
Oh, is
that
that not a phrase here? Okay.
most of
I've
us
learned another
Americans.
one.
Yeah, so don't question me in trying to over communicate with you, Dr. Nick. I won't have it. I won't be part of it. Adore. And Don Norman is a diplomatic person, and he would never put it this way, but I'll put it this way. If your door requires instructions for use, you have designed a bad door.
Right on.
Okay. Right. And so by instructions of use, if you need to tell me how to use your door, if I need to be told that I should push on this side and pull on that side, it's a bad door.
Can
And
I just, as a quick side note, then all toilet doors in aircraft need to be redesigned, because I actually have a true story of somebody that, and this happens all the time, that got stuck in the thing and literally took the whole door off the hinges because they got panicked and handed it to the flight crew.
I've explained myself with this, Dr. Nick, and I was very anxious and I wanted out. And I kept pulling, but I guess I was supposed to push. All right, there maybe are exceptions to that rule, but in general, doors do not require instructions,
Right.
or should not require instructions. They're just poorly designed, and kind of once you have a very basic or elementary understanding of a lot of this, you can avoid accidentally causing your patients to become divorced. See how I did that? I just turned that right back into
Right back. That was the
your.
perfect segue.
And I said patients. I think I meant clients. That's just where my head is.
User design. All right. Remaining time that we've got, wanted to talk about the NPAC, the National Physician Advisor Conference, which I attended. And my first time, I was not aware, although I feel like I've been part of this group for a time, certainly a period of time. Absolutely fascinating. Hands down, one of the best conferences from a content standpoint. It is essentially all the physician advisors. So this is a new group. And, to give you a sense of it, they've only been in existence for 10 years. It's really new. And it is the clinical folks who perform the function in many facilities, sometimes outsourced a variety of these approaches to the denials, the appeals that go on when a hospital bills for something and the insurance company or Medicare, Medicaid deny it based on failing to fulfill the necessary elements that are required to be able to be paid appropriately. And truly fascinating. I mean, all sorts of tremendous insights. I felt like I was with like-minded people, and a lot of them. It didn't hurt that it was in Coronado Beach, and it was a little bit chilly. I'm just going to say, when we did the sundowners on the beach and the sun went down, everybody scurried scurried back to the hotel because it was a wee bit chilly, as they say in Scotland. But it was a tremendous, highly recommended content, and I learned a lot. I was a little bit concerned that this was revealing a number of secrets potentially, and this seems it is almost competitive. I know it shouldn't be, but if we could work more together, it would be a better thing. But that wasn't what was going on.
So these are the doctors or others who are don't work for the big insurance companies, right? That's what you're
Yes,
saying.
yes,
Okay.
exactly. And I'm imagining that there's probably a corresponding conference like there is in all these things where the other side of the coin. I got to say, I would be interested to attend that. Wondering if some of those folks were attending this one, but don't know if that's the case.
Well, if we have any listeners who want to send out an invitation to you or myself, we are open to that.
Yes, absolutely. I would be delighted to attend, and it doesn't have to be in a fancy schmancy place. Although this was, hey, Coronado, fantastic. It wasn't the whatever the what's the Coronado Hotel, I think, which is the one that's most famous. It wasn't actually at that, but it was down the beach. I drove past the Navy SEAL training beach, which is all fenced off, and I asked my Uber driver, I said, do you ever see it? Oh, he says, only at night. He says, comes alive. And I'm thinking, whoa, hat tip to them. So anyway, we find ourselves at the end of another episode, exploring healthcare's mysteries before they become your emergencies. Until next time, I'm Dr. Nick.
And I'm Dr. Craig.